So we're coming to the end of our day, and we're going to focus on the question that people love to ask me. So, what has California done for the last 4 years with ARRA funding? And we have made great progress, which you're going to hear about. We still have wonderful potential ahead of us. And so these are the folks who've been assessing the progress that we've made specific to HIE around California, and they're going to share with us the progress that they've seen and the challenges that they've identified that will need to be addressed as we go forward. Some of which some of you will know some of the challenges. Some of the challenges may sound rather new. This session is going to be moderated by my friend Dan Glaze from Glaze & Associates, and he's going to introduce and moderate this panel that is called Assessing HIE Progress and Potential. So Dan?
Thank you, Pam. It's really my privilege to get to be the person that kicks off this panel today, which is going to be giving you an assessment of the progress and the potential of HIE in California. They're going to be talking about some of the trends, the obstacles, and best practices that seem to be emerging, especially with a focus around community HIOs. We'd like to begin by showing you a graphical illustration created by Czech IPHI that shows the migration of community HIE initiatives. If we could get that graphic illustration to come up. Czech IPHI, which is part of the UC Davis Health Systems, put this together, and it shows since 1996, that was 17 years ago, the migration of community HIEs. And you'll see right around the year 2011 an explosion of growth that coincides with the infusion of ARRA funds and programs, and tells the story of both fully operational and emerging community HIOs. Some of them survived, some didn't. Some are transmitting data, some are not yet. But overall, this shows graphically the evolution of a healthcare communications infrastructure that really seems to be picking up critical mass. We call it HIE. It seems to be here to stay. So let me introduce our panelists. First of all, Dr. Robert Miller is an adjunct professor of health economics at UCSF, where he conducts research on economic, organizational, and health policy issues related to HIT, and among other things, he's been the principal investigator for the ONC-mandated evaluation of Cal OHI's HIE programs. Next will come Raina Kaplan, who's the senior program officer at California Health Equality, which is part of IPHI at UC Davis Health Systems. And Raina's worked really closely with Cal OHI and other statewide HIE stakeholders in the areas of statewide HIE activity assessments, technical standards, HIE resourcing, and the design and administration of the grant programs, which have been incredible in infusing funds just in time that has helped some of these HIEs get combustion. And lastly, our closer is Libby Sagara. She's a health IT and management consultant who's been involved with numerous statewide HIE-related projects over the year, and she provides program management, strategic communications planning for health information exchange, health IT, telehealth, and mobile health organizations. So we thank the panelists today, and we welcome Dr. Bob Miller to start us off.
So I'm going to go through some of the findings from the evaluation of the federal award to the state for health information exchange. This is an evaluation that started in the summer of 2011, and I obtained data primarily from interviewing many stakeholders, as well as from meetings and a few other sources, looking at the status and progress of HIE in California, the barriers to HIE, how the state addressed those barriers, and what barriers might remain going forward. In this presentation, I'm going to do things a little bit differently because I'm going to talk about progress from the perspective of different kinds of health information exchange, because all HIE is not created equal. They differ in terms of functionality and their reach, how complete the data are, and their cost, and to some extent, how quickly they can be set up. So, I think as folks have heard, there's been real community health information organization progress, especially if you contrast it with the situation in 2009, 2010. In large market areas, Inland Empire and Orange County are two market areas where health information exchange efforts are doing exceedingly well, and they're doing well in San Diego as well. In those markets, they have recruited paying participants and have been building infrastructure and testing that infrastructure. There's some go live in terms of organizations providing data regularly, but there's still little use at this point. So those are some of the best examples of community HIOs. In some smaller markets, Santa Cruz has been at it for a long time, doing a great job. Recently, several market areas have stepped up and are engaging in health information organization activities, mostly contracting with existing health information organizations, which gets the job done much more quickly. In Los Angeles, not a trivial part of California's population, the story has been more mixed. There has been, Lanes has been building infrastructure, and some testing has gone on. At the same time, it remains a safety net health information organization, and there's still a ways to go before it's going to be widely used. In the Bay Area, HealthShare Bay Area is still in the discussion phase, so there hasn't been infrastructure building. And then in a couple other areas, well, they remain white spaces, although those white spaces have been shrinking. What's interesting about the community health information organizations is that their functionality tends to be pretty robust. So they have a master patient index and record locator service, which makes it easier to match patients and find information. And beyond just looking up data, they can provide the capabilities of generating alerts about an ER visit or inpatient admission or discharge. They can make for easier submission of public health data, and they can do things like tracking of ACO patients and more. Their potential reach is greatest in terms of patient data and providers, and their cost is potentially very low. Looking at it from a health economist perspective, the marginal costs are very, very low, because they get economies of scale and scope. So it makes it possible for organizations, many different kinds of organizations, to come up with some kind of business case for participating. So another type of community HIO is what I call the automatic push model in the North Coast, which is doing well. Large enterprise health information organizations have been on the move. They are doing the bulk of the heavy lifting for health information exchange in the state and comprise almost all use. But there's less progress than some might think because the functionality varies a good deal and is limited in some cases, which affects usability and usefulness. The reach of these enterprise HIOs tends to be narrower than community, and the cost for trading partners ranges a lot from nothing to prohibitively expensive. But they can be quick to put up. Sometimes there's no alternative to doing it, and in some cases it can meet a lot of business needs. A third type of health information exchange is using the HealthyWay protocols and eHealth exchange. Now, there's not much implementation and use of that, but there's been a lot of activity to try to change that situation to build a California version of HealthyWay eHealth exchange. However, the functionality is more limited. That said, it's got potentially wide reach, and the cost can be low. Direct, which is something that the Office of National Coordinator has been very enthusiastic about, has not found much implementation in California or use, in part because its functionality is so limited. It's secure email, but its potential reach is wide, the cost is low, and it could help a lot of small practice physicians achieve EHR meaningful use, so it may grow fast. What's very interesting is that there are hybrids of all these types of health information exchange that are emerging, where you've got different kinds that are playing very well together. For example, community HIOs and enterprise HIOs in some situations. So, how have the Czech state programs done? Well, backstory is important to provide some perspective, because if you go back to 2009-10, the situation statewide health information exchange in California was fairly poor. Second, if you look at what the private sector wanted, it wanted a very limited role for the public sector. And it's what I call a privately driven, publicly assisted HIE model. And the third thing is that while $40 million sounds like a lot, it sounds less good if you divide it by population and the number of years. Overall, the programs helped community HIOs a lot. And I think one could make the case that Orange County and Los Angeles would not nearly be as far advanced without the money. And if you look at ARA funding, the Beacon community funding for San Diego, you can make the same case there as well. And it's been crucial for community HIOs in smaller markets. It's helped Inland Empire develop public health and other capabilities. But the programs have also showed the limits of money. You can throw money at a problem, but it ain't going to work if you don't get large organizations participating. And that is the case that has been the case so far in the Bay Area, and hopefully that will change. The programs also have helped further use of HealthyWay, eHealth exchange, and generally inter-health information organization connectivity by improving the trust environment. The state and Czech were instrumental in helping set up the California Association of HIEs, which provides private sector governance of California HIE, and it got players to talk to each other, and there was a lot of building of directory and trust services, which is important. So in the interest of time, and I would say that the state efforts have also helped providers achieve EHR meaningful use, primarily through public health related work. So I'm going to then skip to the prospects going forward. A fact of life is that there's very little use of health information exchange in California, and we should all be very clear about that right now. That said, momentum is good for various types of health information exchange. There are many health information exchange tailwinds. I find any of these really interesting. For example, the dual eligibles, expansion of that requires closely managed transitions of care, which requires health information exchange. Community HIOs are going to finally go from talking about what they can do to demonstrating the value of what they can do, which could make a real difference. While the prospects are good, there are obviously important headwinds. Some large organizations are still hesitant about health information exchange. Some, for for some good reasons, but there's also a concern that data liquidity could lead to loss of patients, which is not an okay reason. And that's some large organizations. Another problem is patients are not engaged, so they're not pressuring organizations to do more around HIE. Government support is diminishing. Small practices connectivity remains a real problem. And a lot of patience is going to be involved because the HIE ramp-up takes a lot of time going from infrastructure building to actual use. And so I've exceeded my time. What I can do is just leave you with my questions about the known unknowns going forward. And they have to do with the role of HIE, the state federal government's role, when will patients and consumers engage, what are the pros and cons of different types of health information exchange and combinations of health information exchange, and how long will it take until we get far, far more HIE use than we have right now. So that's a synopsis of the evaluation findings. Thank you.
Thank you, Bob. Next up is Raina Kaplan from Czech IPHI.
Okay, well, thanks, Bob. I think, is it time? Just go. Quick. Okay. So I'm going to talk about, for a couple minutes, 2 examples of progress. And if I seem like I'm speed talking, I probably am, because I want to leave time for Libby to speak as well after me. And I'm going to talk about 2 examples of progress on the HIE continuum, one on the emerging HIO front and one on the operational HIO front. And you'll hear me echo a lot of the same observations that Bob just talked about and a lot of things that have been brought up earlier today as well. This here. So first, on progress on the emerging HIO front. October 31st, 2013. So that date, it's not just an important date because that's the date of Halloween. And at this point, I wanted to, throw out candy to the crowd, but couldn't really get that together enough. But it's an important date because it's a date that history was made in California, from my perspective, and a tipping point was achieved when 4 emerging HIOs encompassing 16 rural counties committed to HIE by signing contracts with 3 different Czech rural HIE service providers. And there they are, located in all those areas. That Sac Valley MedShare signed with ICA, Connect Healthcare, and the Central Valley HIE signed with Inland Empire, and San Luis Obispo joined Acprio as their service provider. And what this really means is that HIE options were created for more than 50 healthcare organizations in those counties, including all sorts of organizations, acute care hospitals, community clinics, critical access hospitals, public health is at the table, behavioral health, a lot of the same organizations we heard folks talk about earlier. 1,500 licensed MDs, and then, the potential to impact really many, many potential lives within these largely underserved counties. So it's a real major step forward in the maturation of HIE initiatives in California. And so the next question that, I asked myself is, how did this happen on October 31st, 2013? And in my opinion, it was the convergence of really a number of factors. First, the check subsidy. Money is always good, always helps move things along, but as we know, money alone doesn't really accomplish everything, and just throwing money at a problem doesn't really always create the solution that you want. It's the community champions, it's the human factor involved, and in this case, it's the Jim Hausensteins and the Lyman Dennises and the Rob Kolkowatz and the Steve Hansons that really made this happen, working collaboratively, doing lots of work in their communities to push them through to this point. Just as, those folks are doing the graphic, they're really putting the building blocks together and making this happen. And then deadlines, of course. Deadlines with the check funding going away, deadlines related to meaningful use coming up, and of course, deadlines related to changes in payment related to health care in general that folks are always thinking about. Other things included just increased penetration and EHR adoption, without which this kind of conversation couldn't even happen in these communities. And then the options related to that lower the cost of being able to do this. As Bob talked about, another shade, the options to buy versus build something that will enable you to share clinical data electronically. We also saw lots of pooling of counties in these initiatives to increase volume and lower cost as well. And then the choices of HIE models that are in existence now to really be able to match the unique community need with the HIE service that folks wanted. You know, they didn't have to fit into a one-size-fits-all HIE model, and were able to obtain what they wanted, ranging from, you know, certain initiatives wanting to focus on direct, others wanting a centralized data repository to pool data to be able to do analytics on that. So it really able to match needs in that way. And then the hospital council's involvement was really essential here, acting as a neutral convener to bring oftentimes competing systems together at the table and helping to facilitate in that role. So my second example here, just moving a little bit back over on the coast, Northern California's Redwood MedNet. Most folks are familiar with this organization, and I just want to talk about their expansion and growth in clinical results delivery during the high-tech era. So over the last 3 years, they have increased from 8 to 40 entities served with their focus on resource-constrained facilities, and from 2 to 7 counties in their geographic range. And Will's model, you know, is really focused, as he puts it, on being able to, being part of the supply chain and getting the raw materials or the key pieces of data, the clinical information that providers need securely integrated into their workflow and into their EHRs, so they can have the right information to make the right clinical decisions at the right time. And that's what this graph is displaying. This, you know, really great graph over there is exactly that. It's showing a 1,000% increase in results delivered, mostly lab results delivered directly into providers, EHRs, into their workflow monthly, and mostly lab results, like I said. But Redwood MedNet is also moving to add radiology narratives and encounter summaries in 2014. So the bottom line is that this, to me, shows a real, tangible example of progress on this front of enabling providers to meet meaningful use and become more efficient in their workflow. And I can end there.
Great. Thank you, Raina. Our final presenter on our panel is Libby Sagara. Thanks, Libby.
Hi there. We have some slides. Great, thank you. I'm Libby, and I've been working for the past few months with Object Health on a CHECK-supported program to determine LA safety net providers and community providers' needs for health IT-enabled care coordination across the county. We're focusing on the safety net, and today I want to tell a few interesting, hopefully fun, stories about innovation, about progress, and about challenges. And I have to press this, don't I? So I'm trying to wake you up a little bit. I'd like to share a few examples, some quotes and stories. And the first story I want to tell you about is from Altamed. Felix Carpio, CIO of Altamed, told us a great story. He has a very large clinic organization across the county. They've spent millions of dollars on the EHR implementation, and I'm preaching to the choir, as you all know, that EHR implementations cost a lot of money. Over the years, they've realized that their EHR is not going to fit the bill in terms of meeting their needs for meaningful use in the next stage without significant upgrades. So in order to upgrade to get to that level, they'd have to put millions of dollars more into that system. Without wanting to do that, they decided they developed their own solution. So with Altamed Net, they hope that they can meet these HIE requirements for meaningful use stage 2. So belt and suspenders. We have an EHR, but we need another solution on top of that in order to meet these requirements. Okay, so maybe you need some more coffee. All right. The next story is one that just piggybacks on the stories we heard earlier today about patient permission. I think most of us here were alive and watched TV in the 70s. I don't see too many young people in this room that weren't around then, but you remember to tell the truth. When you had three people standing up there telling you who they were all the same person, you had to guess who the right one was. So any MDs in this room, clinicians in this room, understand that it's challenging to identify a patient. So I picked a common name, Will Smith. And I thought, how many Will Smiths do I know? I know the famous actor, that's the middle guy. And I know the guy on the left, that's my neighbor, his name is Will Smith too. The guy on the right's my dad, I just needed another picture. And I didn't want to have to ask too many people for permission to use their pictures in my slide deck. No, okay. So permission is a challenge. There are some pilot projects we know that are resolving this issue and really working to acknowledge that even though HIPAA is in place and we all know that these providers have access to their patients' records for the purpose of care, it's still a big concern. And it's maybe not a concern in terms of they're meeting the legal requirements, but in terms of process. So we have great pilot programs. Nina Vaccaro from Southside Coalition has started a great collaboration with Daughters of Charity, St. Francis Hospital. We have Transworld, who's in the room today, who's supported that with their technology. They have the ability through an MPI to identify the patient that's discharged from the hospital before they're routed through Southside to their right patient-centered medical home. But now the clinics are realizing, we've gotten this patient, now what do we do? So just process-wise, how do they address those patient permission issues? All right, my next story is about the great innovations that we're seeing among community clinics and health centers in Los Angeles. The question here, does the early bird get the worm? We all know that we are so happy that we have early adopters of technology. We're glad that there are those who are ready to jump in and adopt EHRs. And we're seeing that often the community clinics in Los Angeles specifically, and those who've jumped to be involved in this project that we're working on, they're ahead of their partners in terms of health information exchange locally. So they may have already adopted an EHR and they're waiting for the hospital down the street to get up and running on theirs, or maybe do their upgrade, or maybe change to the new system that's not going to be up and running until July 2014. So a great quote that we had from Ellen Silver. She is the director of nursing at Northeast Valley Community Health Center. Northeast Valley Health Center. She said, oh, I'm skipping ahead of myself here. I'm sorry, I'm gonna go back to one other quote from Carmen Tectulian from El Proyecto del Barrio. She is already up and running on her EHR. She's waiting for her hospital to get up and running, and in the interim, speaking of Mike Hogarth's note bloat, when she receives an OB patient, has 2 inches of notes to pour through to find the right information on her patient. So does the earlier bird get the worm? She has her EHR, but her hospital doesn't. And I'll go to my next slide now, since I was jumping ahead of myself. Searching for the end of the rainbow. My quote from Ellen Silver was, we're all sitting around waiting for the pot of gold at the end of the rainbow, and in the process, we're hindering patient care. We're really getting in the way of our ability to treat patients because we're waiting for the perfect solution. So we're seeing that there are these pockets of innovation to address that. There are community HIOs, there are enterprise HIOs that are getting up and running. There are still hopes that there will be an overarching safety net solution for health information exchange, but in the interim, people are realizing they cannot just wait for the pot of gold at the end of the rainbow. So we just wanted to applaud those innovations that we saw in Los Angeles. And I think I'm going to pass it back to Dan.
So I want to applaud the panel and all of you for hanging in there. Thank you for that look at how the world looks and what the future looks like. Thank you.